I'll just share the screen. Can you see my screen?
Yes, we
Can
can.
see it, ma'am.
Can you see the screen?
Yes, ma'am. Seen.
Okay, right. So I think this is what we all obstetricians dream of, but sometimes this dream can turn into a nightmare. And we have a baby with Down's, thalassemia, or heart disease. And as WHO says, that 3rd of March was the World Birth Defects Day, that the load on the nation and on the country and the world is actually too much now. And it has increased, because we are able to control infectious diseases, diarrheal diseases, so congenital malformations, birth defects. The percentage has increased from 6.2 to 9.2%. It's just too much. Of these birth defects, it's basically the chromosomal problems, and then we have exposure, teratogens, singleton disorders, multifactorial disorders. But even now, almost 50-60%, we do not know the causes. Just to recap, the commonest chromosomal defect is trisomy 21. And then we have 1813, sex chromosomes, and some other or rare autosomes. So, prenatal diagnosis screening has been defined many years back as the identification among apparently normal pregnancies of those at sufficient risk of a specific disorder, which should be serious enough to justify an invasive technique. And of course, the screening technique does not confirm the diagnosis, nor it refutes it, but actually it picks up a high-risk group who needs further investigations. So what were all doing, that in the first trimester, we were doing ultrasound and the dual marker screens. Second trimester also, which actually started before first trimester, we were doing the quadruple marker. And of course, if there was any problem in the first trimester or the second trimester screen, we would confirm it by doing chorion villus sampling or amniocentesis. But now we have a very important instrument in our hands, which is called the non-invasive prenatal testing. It goes by various names, screening, NPS, etc. So now in the modern era, what we do is a dating scan because that's necessary at around 8. I prefer 8 to 9 weeks. And then the NIPT can be done after 10 weeks. And then it is the first trimester scan. The better time, though it is the 11 to 13 plus 6 week scan, is around 12 weeks, where we can identify other markers of chromosomal abnormalities and even fetal defects. But most chromosomal, the microdeletions and microduplications, they are not sensitive to ultrasound. And let us see whether in the future we can develop all this. I'm sorry, I got a bad throat. Historically, fetal cells have been tried to, actually give us, from the maternal blood, to give us an idea about the genetics of the baby. But there were many years of research, did not amount to much, and are literally given up. However, it was in 1997 that Dennis Lowe, he actually detected fetal DNA in the maternal circulation. And the next year itself, he could actually do the chromosomal analysis of fetal DNA from the maternal blood. So this actually involves this cell-free DNA. And this is now widely adopted for prenatal screening for the 5 more common aneuploidies. So basically what happens is that the cell-free DNA comes from the apoptosis of the fetal placenta, not really from the fetus, and are circulating freely in the maternal bloodstream. So basically the origin, as I said, is placenta, not the fetus directly. This availability of NIPT has been first in Hong Kong, and then it quickly spread to the United States and has actually changed traditional screening. It can be done as early as 10 weeks, anytime during the pregnancy up to birth, and can have a very good correlation with chromosomal abnormality and even avoid the potential harms of miscarriage and other problems of an invasive CVS, or an amniocentesis. So approximately 10% of DNA in the maternal blood is from the fetus. The rest is in the mother. And it can be used as a first tier test, but now it is most commonly used as a second tier test. So first tier is done by the dual marker or the quadruple marker. And if there is a problem in those screening, then we resort to the NIPT. But NIPT is not good enough to replace ultrasound. And most of the companies that do this very sophisticated test are located in USA, the Sequinom, the Verineta Health, and all of them have their different, they're very much almost the same, but different rates of sensitivity and specificity. So Natera happens to be probably the only one which gives a 100% uh, for the sex chromosomes. The others are not very sure about the sex chromosomes. So traditionally, what we have been doing in the first trimester, we are doing the NT scan and the bloods, and all the second trimester also we're doing the quadruple. We are no longer doing the triple screen. And people have done integrated screen, but we mainly use the combined screen, which combines ultrasound for nuchal translucency and the biochemical test for PAPE and beta-HCG. See, on the right side, you can see the detection rates, and they have a very high false positive rate of 5%. But if you see this slide, it tells us that NIPT goes way above. So for the detection rate for trisomy 21, it's almost 99%. For monosomy, even it is like much better than the dual marker. So this was a study performed by Professor I.C. Verma, 10 collaborative centers, and he found that of all the cases who were of high risk and intermediate risk, only 3.8% were actually high risk. So we were having a lot of false positives. But also there was a problem that with the NIPT, they needed to do second tests sometimes because the first test would come as a no call. And 1 to 6% of women would need a second blood draw. And out of these women, about 3/4 would receive a result, and some of them would still not have a result. So actually, the very high positive predictive value. So if you take, for instance, 100, in the first trimester, 3 will be truly positive, and 97 actually will be false positives. But with the NIPT, it's the other way around. 91% will be actually true positive, and only a very small percentage would be a false. These false positives are usually because of placental mosaicism, vanishing twins, mother has a problem, or even neoplasia, apoptosis of cancer cells in the mother's body, could also cause an increase in NIPT. And of course, placental mosaicism, as I said, confined that to fetal and maternal. So these are all confounding factors which can give us a false positive test. The commonest indication as of now, I always tell patients that in AIMS, 20 years back, all women who were above 35 years of age, we were doing amniocentesis. But now we have an alternative, non-invasive, which is a cell-free DNA. And then if there's a previous history of a baby with Down syndrome or a previous child with 13, 18 died, then also we can offer NIPT instead of doing an amniocentesis directly. But the commonest indication happens to be when you do a serum screening in the first trimester or in the second trimester, and you get a high risk report. Then you need to confirm it. If it is very high, more than 1 in 250, we go directly for an amniocentesis or a Korean villus sampling. But if it is the intermediate group, in between 1 in 250 to 1 in 1,000, we would better opt for a non-invasive technique. A report usually looks like this, that the summary comes as high risk for trisomy 21. And as you can see in this report, the others are low risk. So what happens is that you may not get a report, because of the fetal fraction. Here you can see it is 8.3. So the failed test is usually because of a low fetal fraction or there has been a failure in the assay. The report comes as either positive or negative, whereas some companies, they like to give it as more than 99% or high risk or low risk. There is nowadays some companies which talk about advanced NIPT for the rare autosomal aneuploidies. And as this report shows, you can actually see right up to the 23 chromosomes. And but there is not enough evidence that the advanced NIPT is very sensitive. So it is still being studied. So when you get a positive NIPT, the false positive and false negative results, which are actually lower, but the negative NIPT results are usually not confirmed because the false negative are usually very low, but the positive results from NIPT may not always be an abnormal aneuploidy. So we need to confirm by a diagnostic testing. If it is in the first trimester, by Corinne-Villus sampling, and if it is after 16 weeks, then by amniocentesis, before we give an option for a termination or the continuation of the pregnancy. So the NIPT is still a screening test, and it needs to be confirmed by a diagnostic test such as Corinne-Villus sampling or amniocentesis. Therefore, it is very important for us to counsel these women who go for an NIPT, pre-counseling, pre-test counseling, but more importantly, the post-test counseling. So for a positive NIPT result, I said that we would always refer for an expert genetic counseling, and usually an invasive testing is offered for the confirmation. An ultrasound is done, also a genetic ultrasound, to see whether there are any obvious malformations, which again point towards a chromosomal abnormality. Sometimes patients do decline invasive testing. So these are the ones we have to, counsel very carefully. If the NIPT is negative, though we know that false negatives can occur, we can still say that we do not need invasive testing, but follow the patient up with an ultrasound. And again, serial ultrasounds can be done. We also get patients who, once they have an NIPT abnormal, they would want to have an invasive testing and they want to be actually 100% sure. So you cannot refuse them the advantage of a invasive testing. There are many challenges for the NIPTs. Most of it is the fetal fraction of the cell-free DNA. This fetal fraction is actually the proportion of fetal origin, which is floating in the maternal blood. Usually, it averages about 15 to 20% between 10 to 20 weeks. But we take 4% as the lower cutoff. This is NIPT results are heavily influenced by the fetal fraction because lower than 4%, some companies take 3%, reduces the extent of deviations from the aneuploidy and could lead to false negative or intermediate results. So if the fetal fraction is too low, we call it as a no call or a test failure, and we may advise a repeat testing. Some of the conditions which are associated with a low fetal fraction are a high maternal BMI, and also second time also if the fetal fraction is low, there has been more association with aneuploidy ranging from as high as 2.7 to 23.3%. So a no call is actually something which has to be counseled thoroughly. This study was published, which says that analysis of more than 6,000 samples, they found that some cases of 13, 18, and even 21 could be missed. This could be because of, again, mosaicism, as we said, chromosomal aberrations in the cytotropoblast, and irrespective of the indication, 2 to 7.3% could have a low mosaic cytotropoblast. So we have to be very careful while analyzing and doing a detailed ultrasound. So fetal fraction increases as the gestational age increases. So if you do them too early, again, you may get a low fetal fraction. In that case, you need to wait for at least 2 weeks before you repeat the next. It could be also low in cases of triploidy. And of course, in twins, I will be dealing with in more details. Factors which are associated with the fetal fraction are that in trisomy 21, the fetal fraction are usually higher, whereas it is lower in trisomy 18, 13, and monosomy X. As I said, it correlates with the gestational age, and there is a weak correlation with the maternal BMI. Slight decrease in fetal fraction with high maternal BMI. But there is no relation with the fetal fraction with regard to maternal age or ethnicity or even a previous Downs or abnormal. So in such cases, NIPT seems to be a very good alternative to invasive technique. So this confined placental mosaicism, if you look at this picture, is basically there is a presence of euploid and aneuploid cells in the placenta. And this could be present in 1 to 2% of first trimester samples. So confined placental mosaicism is that when it picks up just a part of the placenta and it does not give a representation of the fetus. It is confined to the placenta. So, and then there could be also mosaicism in the fetus. But as fetal fraction originates from the placenta, NIPT could be lacking accuracy. So fetoplacental mosaicism is therefore a concern also in Cohen-Wheeler sampling. And if you get a mosaicism report in CVS, we need to confirm it by either doing an amniocentesis or a cord blood sampling. Since this is a meeting organized mainly by the ART people, I want to deal with that in more details because women undergoing assisted reproduction usually tend to be older. They have multiple gestation and they are on a lot of drugs which could alter the biochemical scenario. So NIPT could have therefore higher failure rates, false positive rates because of lower fetal fractions, twins, vanishing twins, oocyte donation, fresh embryos versus frozen embryos. All these have an effect on the NIPT report. Despite these limitations, NIPT still remains superior to conventional screening in ART. In higher order multiple gestation, such as in the triplets, the NIPT, it's reported to be abnormalities as high as 20%. Hence, it is not recommended. The evaluation of NIPT in two twin pregnancies in more than 189 women, majority conceived by NIPT, showed that it did correlate very well with the degree of abnormal cells. One case only was abnormal, which was a very interesting case of trisomy 81 in a monochorionic diamniotic twin, where one fetus was normal and the other fetus, though monochorionic, had trisomy 21. So this could have been that the abnormality occurred after the cell division. So these are some of the pitfalls of cell-free DNA, which represents placental, but not always the fetal genome. Another study by Chen et al. Showed that NIPT in twins in 565 twin pregnancies following ART, it was 100% positive predictive value. So therefore, Nicolaides et al. Has said that NIPT is a reasonable alternative to first trimester biochemical screening in twins, whether they are conceived spontaneously or by ART. Then comes the problem of mentioning twins. Here, this ranges from about 10 to 30%. And NIPT is associated with a lower positive predictive value and a higher test failure. In this study on singleton and ART pregnancy without vanishing twins following transfer of multiple embryos. So false positive NIPT can be there because of the interference of the cell-free DNA from necrotic tropoblasts of the demised fetus. That demised fetus could have been aneuploidy. And therefore, those cells could be still in the maternal circulation. And it has been noted to last for more than 7 to 8 weeks after the fetal demise, but definitely not beyond 12 to 14 weeks. So if you wish to do an NIPT in a pregnancy, twin pregnancy with a early fetal demise, vanishing twin, you need to wait for at least 8 weeks before you can order the NIPT. Because there is a high chance that it would come false positive. Again, in this study, they showed that the failure rate was 7.62 and 1.4% on resampling. So after the first sample, you may resort to a resampling where you could get a better report. So NIPT could still potentially be used as screening after a vanishing twin. The problem is that the risk of miscarriage, which is there in singletons, could be higher in cases of twin pregnancy, and it has been extensively studied. Each of the fetuses compared to singletons contribute lesser, almost just 35% higher, it has been found, whereas it should have been 100% higher. But so that means each of the twin actually subscribes lesser fetal fraction than an individual singleton pregnancy. For trisomy 21, similar to singletons, less accurate for trisomies 18 and 13. So the detection rates were as high as 99.7%, however. Also, it has been studied by Norwitz et al. That you may be able to distinguish zygosity. So if you actually have twins, dichorionic twins, you could say that one of them was normal and the other one was abnormal by doing the zygosity, which they found to be 100% sensitivity and specific. In oocyte donations also, this study of 63 pregnancies following oocyte donation, they found that the median fetal fraction was significantly lower versus pregnancy with autologous ART. Probably there was a HLA incompatibility causing a foreign antigen and so lesser. So all this needs to be studied really because they would interfere in the report of the NIPT. This other study also, it was a large retrospective study of 1611 pregnancies following oocyte donation. The average fetal fraction for the donor oocyte pregnancies was found to be significantly lower. We were just talking about pre-implantation genetics. The invasive prenatal procedure is usually advised after a PGD. But many women decline to have this procedure because of the risk of miscarriage. So some centers are now offering NIPT as a substitute, and it serves very well as an advanced screening tool for verification of a pre-implantation genetic test. So the problems are that the multiple gestations, vanishing twins, maternal mosaicism, maternal transplantation, or even recent blood transfusions, all this, and of course, maternal tumors can affect the accuracy of the result of NIPT. A very interesting thing is that maternal malignancies have been found. This study by Bianchi actually found 10 cases of occult maternal cancers identified after an NIPT test when the fetus was found to be okay. And they found that actually it was the maternal malignant cells which were contributing to the abnormal high NIPT results. Also, studies have shown the fresh versus frozen thawed embryo transfers. Of course, I know that most of you are doing frozen thawed embryo transfers. So they have found that there was a lower fetal fraction following fresh transfer as compared to the frozen thawed transfers. In fresh ART cycles, usually there is a lot of overend hyperstimulation with high doses of gonadotrophins likely to have OHSs, and this may cause placental dysfunction. So probably that was the reason why it happened so. Also, of course, it is to the advantage of the NIPT workers that mostly all over the world, there is an increasing trend towards frozen cycles. In the future, NIPT could be used for non-invasive paternity testing. There have been lots of studies regarding how it has helped in Rh genotype of the fetuses. There is this report where a fetus with congenital adrenal hyperplasia has been identified. The fetal sex determination we know has been used, but there is a reservation, and it still, however, can be used when there is a X-linked medical disorder. So in the future, detection of smaller regions of genetic imbalance, subchromosomal, microdeletions and microduplications could probably be tested by NIPT. Low positive predictive value, however, does not allow ACOG does not allow NIPT to be used for microdeletions as of yet. Another field is single gene disorders. Single gene disorders can also be tested by NIPT, and there are many studies which shows that it has been quite successfully used for the prenatal diagnosis of beta thalassemia. We are now resorting more and more to microarrays, and where we can actually do the CNVs testing. And there are reports, I was so happy to see in this 2024 report that because of the higher sensitivity and specificity of NIPS, that the indication has gradually expanded from just simple aneuploidy to CNVs. And even some cases of XQ duplications have been reported. So a day will come when probably we will not need to do invasive technique, and we shall be actually doing copy number variants from NIPT. But the data is still not very sufficient, though there are reports ranging from 20 to 100%. And so there is a word of caution for the use as of now for NIPT for the copy number variants. So in the end, we see that there has been a decline in invasive procedures with the use of NIPT, especially in the intermediate group. So the superior accuracy of maternal cell-free plasma has decreased almost by 50% in the incident rates of amniocentesis and Korean villus sampling. And the recommendations by various societies have said that both screening and diagnostic options should be offered to all pregnant women in early pregnancy, irrespective of age or risk. NIPT is definitely more sensitive and specific for the detection of trisomy 13, 18, 21 and the sex chromosome aneuploidies. They can be done very early, as early as 10 weeks of gestation. I wouldn't say 9, I think 10 is still better. But it is very important for a pre and a post-TEF genetic counseling to tell them about the pros and the cons. The American Genomic Society also have said that it should be offered when a positive screen is reported for NIPS. This was in 2016. And what they say now is that it could be offered as the first tier test for screening. And because of the problem of cost, that was not really rampant. But now, as it is proving to be so sensitive, that in 2023 document, they have said that it could be used as a first tier. So first tier means they do a routine NIPT screening in early gestation, followed by amniocentesis of severes and followed by ultrasound later on. So many things are going on. So are we overestimating the technology and underestimating the consequences? So we need to talk about the risks, ethical conflicts, and not everybody can afford an NIPT. It is still very costly. So there could be social disparity. But as we say that it is quite a robust test, mainly for trisomy 21 and also for twins. So I thank you for listening to this, and I hope I have been able to cover some of the important points regarding NIPT. Thank you very much.
Thank you, ma'am. So knowledgeable and so full of content and exhaustive. Thank you so much for that talk, ma'am. I think if anybody has a question, please go ahead and ask.
Yeah, I just have one question. I was not able to understand how we can diagnose the, from which placenta it is coming. Because if it is placental depression, apoptotic cells from placenta, how will we differentiate about the zygosity, that which one is which one? How can we, I am not able to make out.
See, that is just one study that I got, and
Yeah.
we are still not using it to differentiate between zygosity.
Right.
So what still remains is that, especially higher orders, in more than triplets, we are not doing NIPT. We are still relying only on the nuchal translucency. But in twins, we are doing NIPT. But if the report comes, especially before a selective termination, elective termination, not selective, elective, people, a lot of people now do not want to have twins. They want to have a singleton. Then I would like to do an NIPT. If the NIPT comes abnormal, then I would like to sample both the babies so that I know which baby is normal. So as of now, and I said also that the zygosity, this has still been tested, and there was just one single report, and this needs definitely to be correlated.
How does it different from donor? That was somebody's question in the chat box. Why in donor oocyte there is a effect?
Yeah, what they said that the donor oocyte is probably not recognized, is recognized as a foreign tissue.
Okay.
Foreign tissue, and therefore the defective placentation may occur.
Okay. Okay. Very nice, very comprehensive and very detailed, ma'am. Everybody must have gained a lot from this. I sure did. Thank you so much for gracing the occasion, and thank you so much for enlightening us.
Ma'am, I have
Thank
a
you for the
question.
invitation.
Ma'am, I have a question. Can I ask the question, ma'am? Ma'am, if there is a twin gestation post IVF conception and a fetal demise happening around, let's say, 11 weeks. So, as you said, we have to obviously give a gap of about 2 months.
Yes.
In that case, ma'am, we go ahead and do our usual dual testing at 12 weeks?
No, the dual testing also will be abnormal. See, the problem is the vanishing twin. Why did it occur? Most commonly, it is because it was a aneuploid baby, fetus. So
Yes,
these
ma'am.
aneuploid fetal cells would remain in the maternal blood, for at least even up to 12 to 14 weeks. So if you do that, and those cells might interfere in the report. If you do it and you find that the report is normal, then it's fine. But if it is abnormal, then you don't know whether it is from the present baby or it is from the vanished baby.
So that would need invasive testing, ma'am, then?
So you wait. And you do it after 8 weeks or so.
Right.
Those cells may disappear and
You
then
do a proper nuchal translucency. No point doing a dual marker. Do a nuchal translucency, yeah. Because you
Right,
see,
ma'am.
all of them comes from the placenta. And it will, all
Right.
this, will also come from the placenta of the vanishing twin.
Right. Thank you, ma'am. Thank you so much.